Good afternoon and welcome to today's SAMHSA-sponsored webinar titled Best Practices in Medicaid Managed Care, presented on behalf of the UConn School of Social Work Innovations Institute. Today's presentation will be recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. Closed captioning is available and can be viewed by clicking the CC icon at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We also have an ASL interpreter who should be seen spotlit on your screen. During the presentation, please add your questions and comments into the chat box, and the questions will be asked out loud for the presenters to answer at the end of the presentation. When the presentation ends, please take a few moments to complete a brief survey that will show in your browser as you exit the platform. Thank you again for joining us, and we will now begin today's presentation.
Hello, everyone. I'm Suzanne Fields, and I will be serving as your moderator for today's discussion on effective managed care strategies for children's behavioral health. And I'm very excited. I'm going to be joined by two colleagues, Amy Munoz, Special Advisor to the Arizona Healthcare Cost Containment System, and Lynn Lyon, Deputy Director, responsible for all behavioral health policy within the Ohio Department of Medicaid. Today's discussion is going to be operational in nature. There are lots of opportunities to improve Medicaid managed care approaches for children's behavioral health. Our focus will be a particular focus on children with complex behavioral health needs, given the challenges in best serving those children, given the customization that's often needed in managed care strategies, and the reality that children with complex behavioral health needs are often served and supported by multiple systems, including schools, child welfare, juvenile justice, and other systems. And many of our Medicaid managed care strategies, our managed care health plan partners have had to make inroads to designing and supporting approaches that really look at the intersection of those child-serving systems to best leverage and support what each system can do to support children and families. For our structure today, what we thought would be most helpful is that we'll say a few overview remarks, and then we'll have Amy from Arizona and then Lynn from Ohio talk about their particular state strategies and how they've customized those approaches to address their needs. We thought then that we would move to one general discussion, and we'll take your questions then that you'll submit through the chat function. Given that both of these states are addressing some of the same challenges, but have come up with their own unique state-specific solutions, we thought that approach of having one discussion time would allow us to deepen the discussion and understand how each of the states went about kind of customizing and creating solutions based on their own local building blocks and their own resources. To start a discussion on the opportunities to improve Medicaid managed care for children with complex behavioral health needs, it is important for us to highlight a few of the newer, some of these have been out since 2021, but a few of the newer requirements that intersect with our discussion today. And at the end of the slide deck, which you'll receive in an email, you'll see links to all of these resources for you to pursue additional information as you would like for your jurisdiction. But there are new requirements that come out that intersect with this discussion, and these include the managed care rule, which establishes maximum wait times, kind of independent surveys to validate those wait times, public engagement requirements, among other very important requirements within the Medicaid rule. There's also the access rule, which addresses many aspects of access to services, including for home and community-based services, which we're often using as we set about systems to address the needs of children with complex behavioral health needs. There's also the section 11004, the provision for CMS to work with states on an overview of their implementation of EPSDT requirements. This has been around and underway for a while, but obviously as that work moves forward, as reports and kind of the common themes come out and additional technical assistance is provided to states, we anticipate seeing further opportunities and the ability for all of us to deepen the work we do under EPSDT to better serve children and their families. And finally, of course, as is listed here, there are several provisions under the Consolidation Appropriations Act, which create new opportunities for Medicaid to work with juvenile justice partners to provide opportunities to better serve those youth also in the juvenile justice system. Now, all of these are in various stages of review by states. I'm certain you all are in various discussions about these in your own state. States are reviewing these, kind of considering implementation, considering approaches, or are implementing. And we'll have the opportunity at the end to hear from our presenters a bit about where they think their state may be going with some of these opportunities and some of what they're learning from these various requirements. And with that, I'd like to go ahead and have Amy Munoz join us and begin to talk to us a bit about Arizona. Thank you, Amy.
Hi, hello, good afternoon, everybody. So as Suzanne said, today I'm going to talk about some of the ways that Arizona has strengthened behavioral health services for Medicaid eligible children. So in Arizona, it's important to note that Arizona's healthcare cost containment system, referred to as Access, serves as the state Medicaid agency, the Behavioral Health Authority, and the single state authority. So therefore, medical and behavioral health Medicaid services are all integrated under the oversight of Access. This single agency oversight began in 2016 when Arizona's Division of Behavioral Health Services moved into the state Medicaid agency. This was just one step among many that the state took in order to integrate behavioral health and physical health services for all Access members. In 2018, Access contracted with 7 managed care organizations for the integrated health services for the majority of its members. Prior to 10/1/2018, the state had 3 regional behavioral health authorities that oversaw behavioral health services provided to Medicaid eligible children, as well as services provided under federal block grant funding. So the illustration here on the slide is a visual representation of that integration. This slide actually shows for all Access members, but since today our presentation is really focused on the children's population, integration for children started with the majority of members in 2018 and was completed in 2021 when Arizona integrated services for all members in foster care under one MCO. Next slide, please. All right. To give you an overview of what the managed care structure looks like in Arizona, Access has 90% of its membership assigned to a managed care organization. As of 10/1/2022, Access has a total of 12 contracts. They break down as 7 unique managed care organizations, and then 2 sister state agencies that also serve as unique MCOs. There are 4 contracts for Access Complete Care Plans, and then 3 contracts for what we call ACC REBA. And to kind of explain what that means, That means that plan serves as both an Access Complete Care plan as well as a regional behavioral health agreement. So at this time for children, those regional behavioral health agreements are responsible for the administration of non-Title 19 funding. So any services that are non-Title 19, and then they also hold the responsibility for statewide crisis response. But at this time, all other services other than those non-Title 19 services or crisis have all moved under those integrated plans, which are the Access Complete Care plans. There are also 3 contracts for elderly and physical disability. And as I had said earlier, there's 1 contract for each of our sister state agencies. So there's one with the Division of Developmental Disabilities and one with the Department of Child Safety Comprehensive Health Plan. Next slide, please. All right, so this slide just kind of gives you a visual representation of the Access Care Delivery System. In this representation, you can see the 7 unique MCOs, but each MCO may have multiple lines of business. And so that's kind of represented here. Also, the MCOs that are highlighted in yellow are those that serve as both a regional behavioral health agreement and as an Access Complete Care plan. And next slide, please. All right, so now we want to kind of get into specifically what our children's system of care looks like. As Suzanne had said, we really want to kind of try to focus on those kiddos with really complex needs. So all Medicaid eligible children with a behavioral health diagnosis that receive behavioral health services receive child and family team practice. So the child and family team creates an integrated service plan, which lists all services that are to be provided. That plan is reviewed and signed by a licensed behavioral health professional, and this plan serves as the documentation for medical necessity for those services to be provided. Arizona has also chosen CalLocus as the standardized tool, which is required to be completed for all children receiving behavioral health services. The CalLocus is really what helps us to determine and establish which children have more complex behavioral health needs. So members with a CalLocus score of a 4, 5, or 6 are assigned to high needs case management. And that's kind of our way of addressing those more complex behavioral health needs and just having a higher level of care coordination for those particular members. Arizona is currently in the process of implementing high fidelity wraparound as the required model of care for that high needs case management. So now we want to kind of talk a little bit about some of the things that we've done with the managed care organizations in order to really kind of standardize some things and in an attempt to kind of decrease provider burden. So currently, our MCOs monitor the caseload sizes specifically for that high needs case management service. We require a ratio of 1 high needs case manager to 25 children. We do ask that our MCOs collaborate on the monitoring tasks. And this process for monitoring high needs caseloads is really a great example of how our MCOs have been able to kind of collaborate in order to reduce that provider burden. So they created one unified deliverable template that allows each provider to report high needs case manager caseloads, and they break them down by the numbers that are assigned to each MCO. And then they actually, providers, so they complete this same template and they submit this template to all MCOs. This gives MCOs the ability to monitor both the total caseload size as well as have specific number of their members that are receiving high needs case management services. So, but this really reduces provider burden because instead of having 7 different templates and 7 different ways of requesting the information from providers, it's really been standardized into one template, and they just have to send that one item that they've completed to all of the MCOs that they're contracted with. And then I'm going to talk a little bit more about this in a later slide, but our requirements for CFT practice are outlined in our Access Medical Policy Manual under Policy 580, which is our Coordination of Care Requirements chapter. All right, thank you. Some additional items that have helped to reduce provider burden by streamlining MCO requirements include things like we have the Arizona Association of Health Plans, the acronym for short, we call them AZHP, but they all of our MCOs belong to the Association of Health Plans, and the association has standardized provider credentialing as well as workforce development efforts. So each MCO belongs to the alliance and also has a workforce development alliance, which Access has a workforce development administrator, and they collaborate with the alliance to ensure streamlined and standardized training across all MCOs. So an example of this would be our process for training our child and family team facilitators. All of our MCOs work together on a process for training what we call CFT champions. These are our train the trainers of our CFT practice model. The MCOs also collaborated on the curriculum for a 2-day in-person training. Access reviewed and approved the process to ensure that it met all policy and contract requirements. And then the alliance has therefore created this one unified way that facilitators are trained. And then Access is required in policy, the tools and process for which agencies monitor the competency of their staff in facilitating those CFTs, as well as their fidelity to that CFT practice. Another process which has been streamlined is our behavioral health clinical chart audit. The Association of Health Plans utilizes an algorithm to calculate provider assignments for the behavioral health chart audit process. So this ensures that each provider is only audited by one MCO. And in this way, they are only subject to corrective actions for deficiencies in the audit by the auditing MCO. Each year, they are audited by a different MCO than in the previous year. So all MCOs use a tool and user guide, one standardized tool that was created by Access in order to audit the providers. And the MCOs actually collaborated on and submitted to Access a process for inter-rater reliability of use of that tool. One thing that our MCOs do that is very helpful, but is not something that we've actually required, is they hold a monthly children's system of care meeting to collaborate on unifying processes for deliverables, prior authorizations, or any other issues that might come up. When needed, key Access staff are invited to attend these monthly meetings. Examples of some of the things that they have created through these meetings include a crosswalk that's really a user guide for providers on prior authorization processes specific to applied behavioral health analysis. This really helps providers to have one place to go because there are separate prior authorization processes, but it really gives them one resource to know what process they need to follow based on a member's assigned plan. And then another thing that was accomplished through these was actually dividing the providers up for monitoring and technical assistance on compliance of use with the CalLocus. That way, not all providers needed to be outreached by every MCO to ensure their compliance. Each MCO was only assigned to one provider for that monitoring and technical assistance. Access also hosts technical assistance for all plans together and asks them to brainstorm on solutions, such as when Access was outreached by a number of behavioral health hospitals that were experiencing delays with member discharge. So this technical assistance led all MCOs to kind of coming up with a solution, which was having a single point of contact at each MCO for discharge planning. And then this contact list was created and shared with both Access and the behavioral health hospitals. Now we can go to the next slide. Thank you. Okay. So the Arizona Division of Behavioral Health Services had published behavioral health practice tools in 2007. When these practice tools were created, they were intended to be educational and they were viewed as aspirational, really what we hope to see our children's system be one day. The goal was to gradually move towards using these tools to monitor the fidelity of the children's system of care in alignment with nationally recognized best practices for behavioral health services with children and families. These practices have been renewed and turned into policy in our Access Medical Policy Manual. This was the 580 that I referenced earlier, but it's also 580 through 587. And these policies really outline our expectations for service delivery within our children's system of care. In changing these practice tools into policy, language was changed from suggestion to requiring that our MCOs ensure that their subcontracted providers align treatment with these expectations. The work groups that got together to transition these practice tools into policies were made up of many stakeholders from around Arizona and various individuals with lived experience in accessing care from our system. Access conducts operational reviews of our managed care organizations. And within the tool that we use for those operational reviews, we require the managed care organizations to show their policies and procedures for monitoring to ensure that care aligns with the service delivery expectations outlined in these policies. Our plans also submit, oh, I think we might have switched too soon. Sorry. Our plans also are required to submit annual network development plans to ensure that each MCO has an adequate network of all provider types within their network plan. They must identify providers that have been chosen as centers of excellence and the criteria used to select these providers. Specifically for our children's system of care, MCOs must have a center of excellence for children in the birth to 5 population with behavioral health needs, children with or at risk of autism, adolescents with substance use disorders, and transition age youth. Centers of excellence for transition age youth can specialize in either transition to an independence, TIP model, and or first episode psychosis programs. MCOs are required to track and report outcome data demonstrating the efficacy in treatment provided by the centers of excellence and adhere to established benchmarks for outcome data for the population served. Each MCO must also have an Office of Individual and Family Affairs. The MCO staff in this department need to have lived experience. The structure looks very similar to that of our Workforce Development Alliance. So the Office of Individual and Family Affairs at each MCO is part of a larger team that is led by Access's Office of Individual and Family Affairs. This team works with members on system issues that they're experiencing, tracks and trends member issues, develops family-friendly one-pager documents to educate members about access requirements and also to assist with system navigation. They host community forums and feedback sessions, and they also serve as the communication hub for communication with members. So Access continues to strive to improve service delivery for children and families. And these are just a few examples of some of the way that we've collaborated with our MCOs to work towards that goal. Thank you.
Amy, thank you so much. You covered a lot of just terrific detail in a short period of time, and we're looking forward to being able to continue that discussion with you during the Q&A portion of our webinar today. And so now I'd like to go ahead and introduce Lynn Lyon, who will talk to us about their work in Ohio. Hi, Lynn.
Hi, thanks, Suzanne. So thank you for having me here today on the webinar. I'm excited to share some information about a program in Ohio. It is called Ohio Rise, and it is our specialized managed care program for youth with complex behavioral health and multi-system needs. Before I get into the features of the program, just wanted to give a little bit of background about Ohio and kind of what brought on this program. So our Ohio Rise program began in July of 2022. Prior to that, Ohio, like Arizona, had a managed care system, a managed care program. More than 90% of individuals in Ohio Medicaid were enrolled in a managed care program and still are a very small fee-for-service population. We had at that time 5 managed care organizations that covered most Medicaid services, a few small carve-out services, but largely covered behavioral health services, physical health care, a fairly mature program. But we were taking on really a reform effort at the Department of Medicaid to really look at how we can better serve individuals and really focused on the individuals we served and looked for opportunities to make improvements across our managed care program. So this was one piece of many larger reform efforts within our managed care program that we were undertaking at the time. But here is where we really went out and talked to stakeholders and listened to individuals, to families, people who have Medicaid coverage and use Medicaid services, and asked them, what they need, where could we help them better? And the kids with complex behavioral health needs really stood out as one of the populations within our program that we needed to focus on. So through all of that work with our partners and stakeholders, we developed the Ohio Rise program. It is Aetna Better Health of Ohio, serves as our single statewide specialized managed care program. And one of the key features of this is that we do use a shared governance model. So we convened, and I'll get into this a little bit in the next slide, all of our kind of child serving agencies within the administration met to really develop and design this program to make sure that we were best serving children, youth, and families across the various systems and programs. This is a program that is coordinated and integrated with other programs. So really looking to bring together local entities, schools, providers, health plans, and families through this program. And also, we're really focused on preventing custody relinquishment. So really wanting to avoid those situations where families look towards custody relinquishment as a way to get services for their kids. So as part of that, we have a small 1915C waiver within the Ohio Rise program that does allow certain children and families to be able to access services that would not otherwise be able to. Our program, or the eligibility criteria for Ohio Rise, it's children and youth who are in Ohio Medicaid. It's either managed care, so they either are already in a managed care plan or they may be part of the small population that's in fee-for-service. They are under the age of 21 and require significant behavioral health treatment needs. We use the Child and Adolescent Needs and Strengths Assessment. So we have an Ohio version of that is used consistently across the state and by other child serving programs to identify youth for enrollment. And then we also look at individuals or youth who have had recent inpatient behavioral health hospitalizations or psychiatric residential treatment facility admissions as meeting the criteria as well. So in this program, a youth would be enrolled if eligible in Ohio Rise, but they would also maintain enrollment in their managed care plan for their physical health services. So it's really is like that specialty managed care model. So they would remain in their managed care plan and then also have the additional benefit of being in the Ohio Rise program. And you also may have a youth who is in fee-for-service and then also has the Ohio Rise program to provide their behavioral health needs. So the services are all of the behavioral health services. So all of the existing behavioral health services at that time were included in Ohio Rise. And then additionally, we added some new services or enhanced some services. So Our priority services for Ohio Rise are our intensive and moderate care coordination service, which we use the Medicaid targeted case management benefit for. We have an intensive home-based treatment benefit, which we already had in place, but made some enhancements to try to really expand access and use of that service. And then we added so we launched the program in July of 2022, and then later in 2023, brought up a psychiatric residential treatment facility benefit. We have a new enhanced behavioral health respite service, as well as a flex funds that really allow the Ohio Rise plan to work with the family and the child and family team to implement the care plan for the youth. And then I mentioned the 1915C waiver that does allow some unique waiver services for a small number of individuals. And then our mobile response and stabilization service, we also brought up in July of 2022. And this is available to all youth in Medicaid, so youth who are covered by Ohio Rise as well as not covered by Ohio Rise have access to the mobile response and stabilization service. Our program was really focused on work we learned from other states around the country who had undertaken similar efforts in the past. That where we were prior to Ohio Rise was finding a lot of kids were needing to go to get services out of home, sometimes out of state, and not as much focus on the lower intensity services. And our future state and our goal with this program really was to bring up those intensive in community services. So that's our care coordination and in-home therapies, the crisis intervention, and the lower intensity services, so that over time we could reduce the need for youth to receive those out-of-home services. So that was our goal for the program. So this slide shows kind of a picture of the Ohio Rise ecosystem. So at the time that this program was developed, the Family and Children First Cabinet Council convened. So this included representatives from our governor's office, as well as our Family and Children First Councils, our Mental Health and Addiction Services Department, our Department of Job and Family Services, the Developmental Disabilities, our Department of Youth Services, Rehab and Corrections, Department of Health and Education. So all of those agencies came together to both develop and design the program and then continue to work together. Although I will note there's been some structural changes within the state. And so, some slightly different department arrangements that exist currently, but at the time, these were the departments that were involved. And those departments continue to meet on a regular basis to really serve in that shared governance role for Ohio Rise. So at the center of our ecosystem are the youth and the families, and they are supported by, of course, the Department of Medicaid, and we provide that oversight of the program and of our managed care organizations. The managed care organizations remain the key plans to provide the coverage for the physical health services and a few limited behavioral health services. And of course, our Ohio Rise plan, Aetna, contracts with providers for behavioral health services for kids, as well as our care management entities, which I will talk about in a moment. And then the service providers, those providers who are contracting with the Ohio Rise plan and the MCOs to provide services. We have a number of working groups that are made up of stakeholders who have been, some with us since the beginning of the program and helped design the program, and continue to remain engaged to do that, continued improvement, quality improvement, and enhancements to the program as we got more mature. But the advisory council was very key in the beginning and early stages in helping the state bring up this program. And the care management entities, our network of care management entities provides our intensive and moderate care coordination using the high fidelity wraparound. They are actually contracted with the Ohio RISE plan to help provide those services around the state in designated catchment areas. And then lastly, we worked with the other state agencies, particularly our Mental Health and Addiction Services Department, on bringing on a child and adolescent behavioral health center of excellence who serves to support the providers in delivering evidence-based practices, training, fidelity reviews, and workforce development. And that really has been a key resource to help our system in expanding these services. And all of this was built on the system of care as the foundation. So, kind of on the left is what our system, probably looked like before. So many entities very invested in serving kids, and, lots of programs and projects out there at the local level. And in our new model, it really puts the child and family in the center. And then all of us at the state agencies, stakeholders, managed care organizations, and providers working together to support the child and family. So the next few slides, I'm just going to kind of walk you through because I think it's important to understand how the program has, started and the progress that's been made. It really is, and you'll see a long-term commitment. So something that's, taken continued effort and work to continue to build and grow. But as of the first year of our program, so as of July of 2023, we had enrolled over 22,000 youth. The first year was really focused a lot on outreach efforts and trying to reach out to children and families to make sure that they were enrolled and engaged and able to access services. We were able to do much of that work before the launch. So, we knew a lot about individuals and youth who were using Medicaid services. So we were able to identify in advance about 5,000 children and youth who were receiving crisis or inpatient services and work to get them enrolled. And then provider recruitment. So that first year, really focusing on making sure we had, the Ohio RISE plan had recruited and contracted providers. So had over 57,000 providers in that first year. And then also continued through that year to make sure that we were really putting the child and family at the center and continuing to hear their voice and leverage the strengths and abilities of those youth and bring up the program. And then another big undertaking was implementing our child and adolescent needs and strengths assessment, so our CANs. So this really is key to assessing kids in a standardized way and making sure that their needs are identified and there's monitoring to make sure they're getting the services they need. And so this was a big effort to get CANs assessors trained. So we in that first year enrolled over 2,800 CANs assessors and conducted over 40,000 initial CANs assessments. So this was, again, a big kind of operational lift, but really a key to the program. Also in the first year, making sure that these new services, so we brought up many new services at the same time. So any of you who have worked in any way in the system, whether you're a provider or a state or a mental health authority, knows the lift it is to introduce and bring up new services. So really working on getting those new services like the flex funds and respite services built and available to kids. And then really we're out in the community meeting with partners to engage, making sure that all of the entities were aware of the program, the justice system, schools, welfare agencies, providers, and other partners were engaged and referring youth when they needed the services. And then also introduced the community-based care coordination to children. So this is really a key part of our model is our care management entities, our CMEs, who are the care coordinators on the ground. We had at the end of the first year over 485 of our care coordination heroes that were trained in helping families, and this included literally thousands of hours of training and education with CMEs in their communities. So then, kind of looking after that first year, which was, much of that initial implementation lift, really focused then on just continuing to really expand those services, and then also very intentionally waited to implement our psychiatric residential treatment facility benefit. So that is a key service as well, but really wanted to spend that first year focused on building the capacity for those community-based services, and then bringing our psychiatric residential treatment program up as a second phase. And then also starting to really look at quality measures, looked at how is our training working for CMAs? How does that need to be revamped? Enhancing our care planning process, strengthening the operations, and continuing to expand the system of care. And as I said before, this really is a long-term commitment. So this is the work, continues. We're well beyond year one now. And I think the next slide has some information about our second year. If you want to go to the next slide, Suzanne. So this was as of May 2024. So at our almost 2-year point, as you can see, we had at this point over 34,000 members. So continuing to enroll and identify and engage outreach youth for enrollment. In learning more about the needs of our population. So we know over 40% have a developmental intellectual need. We have a number of youth who also have legal needs, and over 70% have behavioral health needs at schools. So again, learning more about the population and how to best serve them. We also, since our launch, have served over 3,000 kids in foster care, and are continuing to add new providers of services every week, and continuing to train additional care coordinators, up to over 700 now, that are providing that wraparound care coordination in the communities, and continuing to grow our new services, including the flex funds and the respite services. And, those services really give us the opportunity to work in a creative way to make sure that we can provide services that meet the unique needs of children with intensive behavioral health needs. So that may be the last slide, Suzanne. Yep, I think so. So I will stop talking and pause for the discussion.
Great. Lynn, thank you so much for all of that information you shared. And if I could ask Amy to rejoin us as well. Amy and Lynn now are available for discussion, and I very much appreciate if you will submit any questions you have for us through that chat function. Happy to turn and take those now. Lynn and Amy, one of the questions that has come up, Lynn, you touched on this. Amy, you referenced it in a discussion of Center of Excellence also, is serving youth that have co-occurring behavioral health and intellectual or developmental needs. And so one of the questions has come through, what are some of the ways that your efforts are focused on serving the needs of those children, what you may be doing now, and then what you may be thinking about doing as your programs continue to grow and mature. So Amy and Lynn, I'll be great to hear from both of you. Amy, would you like to start off with that? And then we'll hear from Lynn.
Sure. So I think for us, it's a little unique in the fact that our Division of Developmental Disabilities actually serves as an MCO. So they have some subcontractors under them that, but they actually serve as a unique MCO. And so one of the really neat things that they've actually done recently is design some training specifically for our behavioral health providers on working with kiddos that have these complex co-occurring. And so they actually came up with an incentive program. It was a pretty intensive training. And so they came up with an incentive program that actually allows providers to be paid increased rates if they've completed this training program specifically for treating those kiddos with those co-occurring.
Terrific. Amy, thank you so much. Lynn, how are you addressing the needs of this often underserved population?
Yeah, so I think that's really one of the benefits of the system of care and the high fidelity wraparound model is when that is done to fidelity, the care coordinators are working with the family to identify all of those needs. And then the child and family team that is put together is not just an individual from the Ohio Rise plan. It can be a physical health provider. It can be a developmental disabilities partner that can be part of it. It's whoever the child or the family needs and wants to be part of that team. So I think the really focusing the child and the youth and bringing in those other partners to be part of the team. So kind of getting out of those silos, you need to go over here to get that service, but bring them together. And, I do know that the Ohio Rise Plan has identified many kids with needs that weren't previously identified, especially those individuals who maybe weren't already engaged, weren't accessing services, didn't have a managed care plan. So we have had kind of an increase in identified needs especially with those youth who also have co-occurring intellectual and developmental disability needs.
One of the often challenges is, children with intellectual and developmental disability needs often need behavioral health services. And for the behavioral health workforce, there can at times be a gap in comfort level or knowledge and how to adapt and meet those needs. I know, Amy, if there was a question about any kind of specific curriculum or training that you all might be using in Arizona. If you happen to have that at your fingertips, it's great. If not, we can mark that as something that we can follow up on and provide. But I'm wondering if, through Amy, that training program or Lynn, through your a contract with your University Center of Excellence, your arm for training and coaching, if you have found particular needs providers have or kind of particular issues that you'd recommend to others that they pay attention to in that approach. Amy, would you like to go first?
Sorry, Lynn, I missed your question, or Suzanne, I missed your question. I was trying to see if I could find what our program is called. My apologies.
No worries at all. We appreciate you trying to answer these questions in real time. And for the person who submitted that question, I believe it was Donna Payne, we're happy to follow up and get that information to you afterwards. Amy, no worries about trying to be that specific now when we're having this discussion. But as you all have thought about kind of leveraging how to support the workforce in this particular area, if there's anything that you have found particularly helpful that the workforce needs or that you've had to focus on, I think that would be very helpful for participants to hear.
Yeah, specifically around the workforce. So I know in Ohio, they're a lot further in their wraparound journey than we are. We just have our initial wraparound trainings where we are doing both wraparound and the focus model. So that's an intermediate care coordination model. So we actually have training set to begin at the end of this month. And really what we found, because I know I talked a little bit about our training specific to CFT practice, which is available to all children receiving behavioral health services. But we really didn't have a whole lot of specialized training for those care coordinators that were specifically doing that high needs case management for those kiddos with complex needs. And we really have found that to be a need that there is, a lot of additional skills that are needed to be able to serve those children. And so we are actually set to begin that wraparound training to really be utilizing the high fidelity model. Our high needs case management model has a lot of similarities to wrap around, but it's really not to that same level. And we really want to make sure that we can utilize some of the measures of fidelity. And there's a great part of the wraparound model that includes a coaching element, and you have in-state coaches. And those coaches are then able to really work with individual organizations to determine what their workforce development needs are and where they need some of those skills strengthened around providing that care coordination for kiddos with complex needs. And I'll give Lynn a chance to answer.
Thank you, Amy.
Yeah, I mean, as I mentioned, we have the Center of Excellence that does the training on care coordination. We have the intensive, which is the high fidelity wraparound, as well as the moderate, which is a little lesser than that. And then there's also care coordination that's done at the Ohio RISE plan for those those with less intense needs. And so we do have, included in the competencies and requirements for care coordinators that, we really are looking for those individuals who have experience and competencies with kids with multi-system needs, including intellectual and developmental disabilities, and then making sure there's that strong kind of clinical oversight and supervision structure. So both within our care management entities, that supervision, and then we have the oversight at the Ohio RISE plan level that is able to support those care coordinators. And then, another thing that we determined we needed at the state level is really a strong kind of clinical function and clinical operations team at the state. So, I think bringing up a new managed care plan, we were more used to kind of what we would call the blocking and tackling of managed care, like paying claims and enrolling providers and realized, that's important and those things need to work, but that we really needed to be spending a lot of our efforts on that clinical support and clinical oversight. So we were lucky to be able to hire folks at the department who are very strong in that space, steeped in the system of care, and that work very closely with the CMEs on, especially those particularly complex cases, and can step in and provide support in a real-time basis for some of those challenging cases.
Very good. Thank you so much. And one question that we have also that has come in relates to the education requirements for your care coordinators. And you both have different tiers or levels or types of care coordination. Can you speak briefly to who's fulfilling those functions from an educational or readiness or life experience perspective?
Sure, I can start if you want on this one, Amy. So we do have, so within Ohio, we recognize both, of course, the licensed behavioral health practitioners, social worker, marriage and family therapist, as well as unlicensed. So we have a qualified mental health specialist credential in Ohio, where those are individuals who have that experience and training specifically to work with individuals on their behavioral health needs. All of the care coordinators, whether they're licensed or unlicensed, complete the high fidelity wraparound training, and then have that appropriate supervision at the CME level. So at the care management entity, there is a supervisor. So we do kind of recognize different levels of education. And so we've kind of paired levels of education with years of experience and competencies to, create, we wanted enough flexibility, especially with workforce challenges, to make sure that we could retain and recruit the workforce to provide this work, but also really wanted to make sure that individuals doing this work were, having the appropriate experience, training, and demonstrating those competencies. So it's kind of a a grid of, education, experience, competencies, and then for those with a license, of course, they would have their appropriate license.
Thank you, Lynn. Amy.
And it looks very, very similar in Arizona. I have to say it's very similar. We call ours behavioral health technicians, but they are also unlicensed folks with different combinations of experience and education. And then they're overseen and supervised by a licensed individual that we call a behavioral health professional. So, but very, very, very similar structure.
Very good. Thank you. Thank you. We've received a question, Amy, specific for you, given some of the structure differences you've talked about in Arizona, about how children who are in foster care are served in your state, and what happens from, say, a continuity perspective as those children enter or exit foster care as it relates to changes in health plan and kind of provision of their behavioral health care.
Yeah, so we do have that specific plan. I see that added to the question, they specifically asked also about for individuals with a developmental disability. And so we actually, for children with a developmental disability, even if they go into foster care, they don't leave their plan. So they stay with the managed care that they are with under the Division of Developmental Disabilities. So they have that consistency there. There's also a intergovernmental agreement between our Department of Child Safety and the Division of Developmental Disabilities so that they can collaborate on those specific children. But for the children that are switching plans, we do have some very specific policies and requirements around kind of that entrance and exit. We also in Arizona have a very specific piece of legislation, Jacob's Law, for this population. It defines a lot of timeframes and other pieces, which is why it is helpful to have them all under one plan. But there is a lot of collaboration that we require. We have a specific form when they're transitioning to another plan to provide information, and then they are considered to be a special population even for a year after they exit foster care for that MCO that they're assigned to when they leave our Department of Child Safety plan. So it is something that we have really had to plan around and create a lot of policy around that kind of enter and exit. So that law that I spoke about specifically, one of the things that does is requires them to have an assessment within 72 hours of coming into care. That's an integrated, we do both physical and behavioral health assessment within that first 72 hours. And that really establishes them with a CHP or MCO that oversees those kiddos. And that way they can really start to address those unique needs of kids that have come into care within that first 72 hours. I hope that's helpful.
Thank you, Amy.
If needed, I can provide some of the policies that we have too, specifically around transition.
Yep, thank you so much. Lynn, one question kind of specific for you, given the structure in Ohio, that you have different integrated plans. You have your PIP for those children enrolled in your Ohio Rise program, whose then physical health care is managed by a different partner health plan. What are the ways that you have expected, required, asked those health plan partners to coordinate and collaborate with Ohio Rise? What has worked well? What are some of the push points that you would recommend to others who may be having similar structures or considering a similar structure?
Sure. Yeah, from the beginning, we were very clear with the MCOs as well as the Ohio Rise plan that we were putting the youth and the families first, not the business of managed care. And, our partners are very bought into that. So they've worked well together. We, of course, have strong requirements in our contractual agreements with all of the entities. And then additionally, we prior to implementation required the MCOs and the Ohio Rise Plan, as well as our pharmacy manager, to work together to develop operating contracts with each other. So those operating agreements lay out, they go deeper into roles and responsibilities around how the entities will jointly be serving shared members. We also did extensive training with all of the entities prior to go live. So that included, operational exercises to make sure that there was readiness established across those entities and clarity on roles and responsibilities, of course, protocols and other operational guidance documents were developed. I think in practice, the way this typically plays out is when, for most of the youth in Ohio Rise, their behavioral health needs really are rising to the top in our kind of take the lead in terms of their needs. So it's typically the Ohio Rise Care Coordinator that's in the lead role, and then pulling in as needed the MCO care manager to help support. And sometimes they may even be part of the child and family team if they also have a physical health need. In those instances where there may be, kind of equal physical health needs and behavioral health needs, both the Ohio Rise Plan and the MCO care manager would then kind of work together in a partnership to help support that youth and family. So, again, I think just starting with that philosophy of this is about the kids and family at the center has continued to work, and our partners know how important that is and know that they need to work together.
Thank you, Lynn. Amy, a question for you based on what you shared in some of your slides about how you all have supported your multiple health plan partners to kind of work together in those key areas. Can you talk a bit, as the state kind of Medicaid authority, how you decided what areas you were going to establish that needed that level of collaboration or partnership, and what areas of, say, health plan practice could continue to be individualized or differentiated by those specific companies? How did you kind of arrive at what you wanted to see them partner around?
Well, honestly, I think a lot of it has been driven by feedback from providers. Of course, for our providers, it can be a challenge to have contracts with especially all 7 providers. So I do think that some of it has been feedback driven, what items we have chosen to focus on. But I think it's just an ongoing collaboration thing that, we initially did this in 2018. It's still a work in progress, because I think it's just one of those things that as things come up, we have to address, new things. I think right now we're looking more at prior authorization processes than we have in the past, but it's just as things kind of come up. One of the early things, like I talked about our Association of Health Plans, one of the early things that they did was the provider credentialing, just because that was an initial concern from the providers. And so I think that it's really been driven by that provider feedback.
Good, thank you. Thank you very much. I don't see any other questions from participants today. So I do want to highlight for everyone that there are 2 resource slides that connect you with information on some of the federal rules that I highlighted at the beginning that intersect with Medicaid managed care and opportunities for children with behavioral health needs, as well as resources from our presenters from Ohio and from Arizona, so that you can obtain additional information about their particular program, their requirements, etc. So with that, for closeout, I'll go ahead and turn it back over to Bailey.
Wonderful. Thank you so much for this wonderful presentation. This does conclude today's session. You may now disconnect.